Welcome to Justice, a podcast all about being a big age. My name is Tashara Halyard. I am your co-host.
And I'm Margot Lindauer, your other co-host. Welcome to an episode on menopause.
Something very, very important, of course, when we talk about being a big age. We are going to answer questions. We are going to tell you things that you didn't know you needed to know. It's a great episode, y'all.
It's a great episode. So stay tuned. But let's get started.
Let's do it. Em, what are you sipping on in your Justice tumbler?
Metamucil. Tashara.
Girl, you got to get your fiber in. Yeah, you have to do it. I mean, start early in the day.
And it's not bad. It's psyllium husk with a little orange.
Next episode sponsor shall be Metamucil.
No, just, menopause and perimenopause, which is something we're going to talk about.
Yeah.
Stuff changes.
It does.
And
your elimination. So do you find...
What did you think I was drinking?
I was hoping it was maybe a gin and tonic with a little bit of bitters in it to make it orange.
Nope, not today.
Oh, not today. All right.
What are you drinking?
It is coffee, black, no sugar, no cream, just to kind of, wake me up a bit. I don't usually do cold coffee, but it stays cold in the Justice tumbler, which is really, really nice.
They're really cute.
They're cute. We love it. So if you want to see me in Margot's face, and the Justice logo on your cup of Metamucil in the morning, then...
or iced coffee, or your
iced
smoothie,
coffee.
whatever
it is. Go to our website, and you will be able to grab your Justice tumbler. So we have definitely really been appreciating the community that has been built from the podcast, and we wanted to make sure you all had swag.
Absolutely.
So, Em, tell us to start off the episode something that people don't know about you.
I really like country music.
Stop lying, girl. Are
No,
you
I do.
serious?
You should look at my Spotify.
I didn't know that.
I really do. And I hate it because it's so heteronormative
This
and
is true.
all about drinking and like marriage and love in this certain way, like trucks and what men do and like what a man ought to know. That's a song I really like. And it's kind of my guilty pleasure.
My brother also really likes country music. So there's a there.
Okay.
There's a there. So kind of similar.
Yeah, what's yours?
I think we both have like Southern Confederate roots. Is I love like being outdoors but doing things like fishing.
What?
On everything, girl.
You like to fish?
I love fishing. Like some of my best memories are growing up and fishing with my grandparents, or like my mom one time got me and my little cousin fishing poles, and we would fish in the pond in the back of our apartment complex.
Wait, what?
No, I'm so serious. I really like fishing. I also like going for long walks, hiking. Like I like doing things that are outdoors related, and people would never assume that about me.
No. The fishing, really, I didn't know. So...
Yeah.
Amazing. Okay.
Next Justice retreat.
Yeah.
Country music and fishing.
Maybe. Okay. Dumb shit men say. So this segment has gained a lot of popularity. Thank you to everyone who's been sending us ideas for this segment. There are so many options. We're going to change it up a little bit this season to incorporate more people, not just men, because women also say some dumb shit.
Amen.
And there's also some really powerful shit that people say that we also want to focus on. So we're gonna pick a quote or something of that nature every episode and dissect it a little bit. Today we have, and it's really interesting that it has taken us this long to get a Donald Trump quote on here. I think that's a positive thing, but we also had to.
Yeah,
So
very true.
My fingers are long and beautiful, as are various other parts of my body.
Not that any context for this would be appropriate, but when did he say this and why was my first reaction.
I actually don't know, but why? Why would the president of the United States talk about his body publicly
In this way.
and no one wants to know anything about his fingers or any other part of his body?
None. When I think of someone who I am curious about their sex life, Donald Trump is not on the list.
Well,
not on the planet, not in the stratosphere. That's what I don't want to know because I just vomited a bit in my mouth. Because that shit is fucking disgusting.
Also long and lean.
And who wants that? I don't get a lot of peen. I don't get a lot of peen. But last time I checked, we want some a little girthy.
So I just read this really wonderful book called Erotic Stories for Punjabi Widows.
Ooh,
It's a really good fiction book. It's for my book club. And the women in the book talk about different body parts with different fruits and vegetables. And I keep thinking about it when I read this quote because no one would want a carrot.
Right.
It's more of a cucumber.
Or maybe a squash.
I mean, maybe.
I mean, I'm just thinking of the different.
Ew, Donald Trump.
Ew, I mean, I think that's pretty much the takeaway. But also, isn't this also, you know what it reminds me of too? When it came out during the campaign and he still was elected, how he was on tape saying, grabbing women by their PUSSYs, right? And so clearly this is a man who operates in a certain amount of like vulgarity.
Mm-hmm.
And it is not surprising. I'll just say that.
It's not. And that no one, well, this is a much longer conversation, obviously, but no one's held him accountable for this type of vulgarity. It's
Amen.
almost as though it's all a joke and people continue to ask for it from him, even though they're also asking that he hold arguably the most powerful position in the world where he has to set an example, both personally, professionally, and policy-wise.
Yeah. It is the reality TV star.
Right.
Yeah.
Being president.
So.
And just for clicks.
And likes.
Okay. Let's move on. He's no longer president.
Thank God.
Today we have a really interesting special guest. We are Zooming her in. Her name is Dr. Heather Hirsch. She's currently MIDI's Chief of Clinical Quality. Dr. Hirsch leads clinical training, directs patient education, consults on protocols, and sees patients herself through the MIDI platform. Prior to joining MIDI, she was the lead physician at the Menopause and Midlife Clinic at Brigham and Women's Hospital here in Boston, which is the second largest hospital of the Harvard Medical School. She's an avid educator and dedicated to dispelling the misconceptions surrounding perimenopause and menopause. Dr. Hirsch also has a really large online presence where she reaches hundreds of thousands of women who follow her on social media. She has a book coming out. She has a podcast. I highly encourage you to follow her and learn from her. We will link all of her information in this episode, but also hopefully continue this conversation with her as our episodes continue to come out. I think on a personal level, Dr. Hirsch is also my former doctor. When she was at the Brigham and Women's Hospital, she was the doctor that I saw after my diagnosis. And I was really lucky to be connected to her. And through her, I learned that I was incredibly lucky to be connected to a doctor who had expertise and put importance into this area of health and want to help others access this information as well. So we're thrilled to have Dr. Hirsch on today. But before we talk to Dr. Hirsch, let's get to our sponsor.
For sure.
So our sponsor today is Breathe Cambridge. Breathe is an incredible yoga and Pilates studio in the heart of Harvard Square in Cambridge, Massachusetts. For our Boston, Massachusetts followers, I highly encourage you to go. For our out-of-state followers, which I know are a lot, Breathe also hosts international and national retreats. So stay tuned and check their website for those. Breeze's motto is for everybody and everybody, which I just love. They're a really inclusive space. The yoga and movement classes are the thread that ties the community together, but it's way more than a yoga and Pilates. It's way more than a yoga and Pilates studio. It's a space to laugh, move, cry, grow, fall, and get stronger and learn more about yourselves. I was talking to the owner of Breathe the other day as we were preparing for this episode, and she said something that I found very, very moving, and I think something that we can all appreciate, that the mission of Breathe is to be someone's third place, not their home, not their work, but a place that they go outside of the things they have to do for either work or home. Anyway, it's a really interesting, great space. I highly, highly recommend. And yeah.
Many thanks to Breathe. And let me just say that Margot and I have in common that we both love yoga and Pilates, and it's a big part of our wellness practice. So many thanks to Breathe.
Many thanks. And stay tuned. I know we've kind of briefly hinted at this in season 1. We're going to have more information to share very soon, but there will be opportunities to move with us in person in the coming months through what we plan on as a few different retreats. So
Absolutely.
Breathe will be the foundation for a lot of that instruction, hoping that not only will I teach, but also some teachers from Breathe will participate in the retreat.
Sounds good. Let's get into today's episode.
Okay, Dr. Hirsch, let's just jump into it. Can you let us know a little bit about the pellet controversy? What's a pellet? What's the controversy? And how have you
want to start right off the bat with that?
Strong.
And why are you vulnerable on the internet? Okay, let's just get to it.
Yeah. Wow, that's a good one for your first question.
Yeah.
All right, so pellets essentially. Well, let me actually kind of be really crystal clear here that I don't insert pellets. And during my menopause training, which was always evidence-based, I never learned how to do this. So I might make some assumptions here, but a pellet is traditionally a form of long-acting hormones, whether it's testosterone, estrogen, and progesterone, but it's usually at least testosterone and sometimes estrogen. And it's injected subdermally, usually into the tush, and it lasts for 3 months. The problem with these types of pellets is that they are unregulated, they're not FDA approved, and they're helping to line the pockets of clinicians who do them, quite frankly, which I know sounds terrible. And I'm not trying to say that in of itself is the problem, but it's making women guinea pigs while doing that. That is actually the problem, because there are FDA approved regulated hormone therapy that are safe. So when we're touting these types of pellets, a lot of people are also saying that they're safer when in fact they're actually not. It's just pushing the barrier to get clinicians to better understand FDA approved hormone therapy and then get patients to better understand FDA approved hormone therapy.
So people would get
quite
pellets.
the controversy.
Sorry, go on. People are getting pellets because they.
Right.
Why?
I'm ignorant to the pellet controversy.
Well, so what I think is happening is that women are smart and inquisitive and curious and proactive. So when they go to their doctor and they say, I'm having these symptoms, I think it's menopause, and their doctor says, well, there's nothing you can do, or here's an antidepressant, or I don't believe in hormone therapy. Women are like, no. That cannot be the only answer here. So then they're crowdsourcing, they're asking their friends, they're going on Facebook and they're Googling, and they're finding basically wellness clinics where they will insert hormone therapy via the form of this pellet into your tush. And so saying, okay, well, I need to find a solution to my problem. I'm not feeling well. My clinicians aren't helping. So this must be something that I can do. I'm seeing other people having good or variable results. So let's frickin' do it.
Right. So let's go back, Dr. Hirsch, because you said something very interesting about crowdsourcing and going to your doctor and your doctor not really being in a positive place to provide support. As a doctor who has specialized in menopause, is that something that's common, and why? Right? This is a very common stage of life. Humans go through it.
50% of humans are going to go through it. It's a biological process. And I remember when I met you, it was a referral from my oncologist. I didn't even know there was such a thing as a menopause doctor. And when I started talking to my friends, some of whom have also gone through breast cancer treatment, like Tashira, they'd never even been referred to someone who had expertise in menopause.
Why?
So what a good question. I'll tell you a little bit about my journey. When I went to medical school, the lesson on menopause was a lunch and learn, which was like kind of voluntary. Like if you wanted pizza and to stick around and learn about menopause, like you could if you were interested. but it wasn't a required part of medical school training.
Like
And
nutrition.
then even into my residency, right. In my OBGYN residency, I was an OBGYN resident for about a year and a couple of months. I don't think I ever heard the word menopause even uttered. Now, granted, I didn't do all 4 years, but you can kind of do the statistics on that. And then when I went to residency in internal medicine, it was really not talked about, except for, well, if you have a woman with really bad symptoms and if she's tried all these, antidepressants or SSRIs or lifestyle, and if she's perfectly healthy, maybe you can consider hormone therapy for the shortest amount of time humanly possible. I think the real problem doesn't really fall onto clinicians' shoulders, but the way training is set up. In medical terminology, we have something called the ACGME, or the American Graduate College of Medical Education. And they is this group of, humans who decide what medical students and residents should learn. And menopause is not on the menu. And that's a huge problem because it's actually 51% of the population. And it's not just menopause itself, the event that occurs. It is that menopause should be considered a chronic condition, maybe not a disease, maybe not a syndrome, but it definitely is something that once you're postmenopausal, you're always postmenopausal.
You don't
And
go
your body
back.
is going to change regardless. You don't go back. Your body's going to change regardless. And some women who have chemotherapy or genetic mutations or surgery to remove their ovaries for other reasons undergo menopause earlier, which is actually a completely different physiological process. It's actually fascinating, which is why I love being a menopause doctor, because there are so many different ways that menopause can interweave into a woman's life. But once they do, it is with you for the rest of your life.
And just as a follow-up, Dr. Hirsch, just to make sure that we all have the same understanding, is menopause technically, I've always been told, the period post-menstruation, or does it have a wider definition? What is menopause?
This is a great question. And we use these words in social media a lot, very interchangeably, and even I will. But menopause is actually a day. It's a day that's signifies 12 months of no periods. And this is usually meaning natural menopause, because if you had chemotherapy or some other reason why you weren't getting periods, that might not be menopause. Your periods could come back, for example. But if we're talking about natural menopause, it's 12 months to the day where you have had no periods. And then once you hit that day, that birthday, whatever you want to call it, of menopause, you are always postmenopausal. And then we call the menopause transition really from the onset of perimenopausal symptoms, in which menopause symptoms happen while you're still menstruating up until that 1 year mark of no periods.
Gotcha. Oh, this is so helpful.
Mm-hmm. So we could be in perimenopause, for example, for a decade.
Yes. I think absolutely this is so important to talk about, because symptoms often start for women in their late 30s and in their 40s and have really, really changed the trajectory of their lives, meaning they're either having hot flashes, vaginal dryness, trouble sleeping, anxiety, joint aches and pains, all seemingly different processes, but actually all just one thing from perimenopause. Now, the statistics in the United States are that perimenopause, the average age is 47 in the United States, but I think it is much younger, because that statistic is really based on clinicians accurately diagnosing you with perimenopause and putting it in your chart. And I just don't think that's happening, guys.
Yeah. And I also don't think that people are necessarily going to their clinicians until it's a breaking point, right? So they could be experiencing
Exactly.
irregular periods or brain fog or anxiety or so many of these symptoms are also symptoms of other things
Very true.
in a very busy life, which a lot of people in their 30s, late 30s and 40s have. Most people, all people. And so I could imagine that by the time people go to their clinician and say, these menopause or perimenopause symptoms are too much for me to control, they could have been experiencing them for quite a long time.
Absolutely. That's exactly it. And as women, we are well, we can say this here, right? We're like the most important fabric of society. And, we do so much to keep society running. And we go for far too long, just assuming these things are normal or they're going to
Or something's wrong
resolve on
with
their
us.
own. Exactly. And then all of a sudden, 5 years goes by, 10 years goes by. This is so, so, so common. And then if you're not lucky enough to have a clinician who knows what perimenopause or menopause is, or if you yourself don't know what those things are, because you might not, you kind of end up going to multiple different doctors trying to figure out why your mood has changed, your sleep has changed, you're gaining weight, you have joint aches and pains. And it really puts a bottleneck pressure on women, particularly when they are at their most, functional, or they should be at their peak performance in their mid 40s. And this is again assuming just a natural menopausal course. That's not always the case. And then, you have really you really have a public health crisis that has been really made invisible for far too long.
Ooh, a public
That's
health crisis.
that's a tragedy.
That is so deep. So, what do you find is the most common symptom that people may be embarrassed or ashamed to talk about?
Well, that's a great question. I think the most common thing that I hear from women is that I just don't feel like myself. I used to da 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 da. Da. I used to run marathons. I used to get up early. I used to be able to multitask. I used to be able to enjoy sex. Whatever it is, women just don't feel like their normal selves, which is really individualized. So
Mm.
I would say the most common thing is just this feeling of like missing this former or younger or different or more energetic version of yourself,
Mm.
while all of these other things are going on in your life, right? Whether you're dealing with houses and spouses and kids and pets and jobs and bosses, and put all of this stuff together. But I would say the things that people are most embarrassed to say, which is really kind of just, it only puts a smile on my face because it's so universal, is, weight gain, hair loss. People will say, I know I sound so vain. I say, no, you don't sound vain. These are important things to you. These make you feel like yourself, and that is okay. But certainly, I hear the gamut from, loss of libido to weight gain to loss of muscle definition to just not being able to put their regular clothes on and feel confident about themselves.
Mm-hmm.
Yeah. I've been experiencing that a lot.
What's the middle?
I don't know what the middle is.
Oh,
I don't know.
I heard this term related to, I think, weight gain in your stomach area related to
Okay.
perimenopause. And I was like, oh, yeah,
Okay.
I have that
Oh,
middle.
like so. Yep, I know exactly what you mean. So you know that the mental belly is essentially as our metabolism changes, which it does. One, as we age, let's just say it, our metabolism is going to change as we age, both men and women. But for women, many of us believe that as we lose our sex hormones, estrogen, testosterone, particularly, that also slows our metabolism. So it's a little bit of a trick that we call those hormones sex hormones, where they do so many other things besides for
Mm.
help us get pregnant or help us with libido. They control so many processes in our bodies. But as we lose estrogen, it can really affect our insulin's ability to work well. And when insulin works well, it's doing its job metabolizing carbohydrates and sugars and breaking them down. As we lose estrogen, there seems to be this parallel effect of reducing our insulin resistance. And so, therefore, we start to gain weight. And particularly, either the weight gain is in the belly, where there's just kind of this adipose tissue, or not. Women might not gain weight, but the weight shifts, meaning they might not have gained weight on the scale. This number's still the same, but their pants feel tight, or their breast tissue actually changes and their cup size increases. And that is this belly phenomenon, which essentially means that as we lose our quote unquote sex hormones, it also may play a role in our metabolism. And if there's one other thing I'll say to this, we know from this big study called the Women's Health Initiative, or the WHI for short, that when women took hormone therapy, they had less progression to developing diabetes. And what that means is that when you replaced estrogen as you lost it, women were less likely to get the diagnosis of diabetes. So their
But Dr.
insulin was
Hirsch,
working
can I just
better.
stop you for a second?
Hmm.
All we've heard over the years about hormone replacement is that estrogen causes breast cancer and that hormone
Hmm.
replacement is dangerous. I want to talk about that because not getting diabetes at the same rate that one might get is a really positive health outcome that
Hmm.
I would say up until today's years old, I had no idea.
Yeah, me either.
We also know that women who take hormone therapy compared to women who don't have less cardiovascular disease, have better bones, and live longer, on average 3.2 years longer. But this is a really good question because certainly, yes, one of the biggest barriers about starting hormone therapy is the fears of the risk of breast cancer. So let's break this down and take emotions off the table and just talk about it in terms of pure statistics. Pure statistics are 1 in 8 women will develop breast cancer over their lifetime. So that includes both pre but also postmenopausal. The biggest risk for developing breast cancer that is a not genetic mutation form is age, right? That's the biggest risk factor. So 1 in 8 in age is the biggest risk factor. When the Women's Health Study was undertaken, I want you to know that they used a certain form of medication called Premarin or Prempro. Premarin is just estrogens, and that was for women who didn't have a uterus because no uterus, you don't need progesterone because it mostly protects your uterus. And theirs was gone. Prempro was conjugated equine estrogen and medroxyprogesterone acetate. Now, after 5.2 years, the Women's Health Study in the estrogen plus progesterone arm was closed due to an apparent increased risk of invasive breast cancer. I want you to know at the same time, the women who were taking estrogen only were actually showing trends toward a reduction in breast cancer compared to women who took placebo. And that's really important. We're going to come back to that in a second. In the estrogen and progesterone arm, the media reported a 26% increased risk of breast cancer. If you think about that, that very quickly sounds like 1 in 4, right? That's not what it is. That's absolute risk, and it needs to be changed to relative risk. What does that actually mean if you translate that 26% from that population? Well, the relative risk was 4 women out of 1,000 women over 5 years who took the oral Prempro. So 4 women, actually 2 to 4, but let's just say 4 women out of 1,000 over 5 years who took oral Prempro. That association, it's not a proven, it's an association, is actually less than the risk of getting breast cancer if you have high blood pressure, if you're a smoker, if you have diabetes, or if you have any of those things combined, or if you drink a glass of alcohol with dinner every single day. That risk's actually lower. But the media really kind of drove it home like, oh my gosh, women are getting breast cancer from hormone therapy. If you think about it, right, the majority of women who do get diagnosed with breast cancer because age is the biggest risk factor are postmenopausal when we don't make estrogen anymore. Now, in the estrogen only arm, those women had statistically significant reductions in breast cancer over time, which is pretty wild.
Why didn't they report on that?
You know, ladies, I could make some guesses, but my guess is that it just wasn't seen as very interesting by the media.
So then, Dr. Hirsch, what would you say for someone like me who is a breast cancer survivor? Both me and my maternal grandmother, our cancer was estrogen driven. And so post chemo for me and radiation, I was put on Lupron, which, it felt like I just hit a brick wall. I was
Oh, yeah.
batshit fucking crazy. I mean, my
I
mood
know.
swings were terrible. I was sweating profusely, which caused so much anxiety, which caused me to sweat more. It was just a lot, right? And the advice that I was given writ large was no estrogen. Thug it out. This is what it's going to take for you to be cancer free through the research period that is required of 5 years. So for you as a menopause doctor, who I think should have been working closely with my oncologist and breast surgeon to come up with a treatment plan, but that was not my case. What would you say for those patients who are really struggling with medically induced menopause?
Oh gosh. Well, first, my heart goes out to you so much because I know firsthand how difficult the process is. And there's just so many layers. There's the emotional, there's the social, there's the medical, there's the symptoms. There's just so much going on in such a short amount of time. And you're absolutely right. There is this fear instilled because it seems like estrogen is the driving force of the cancer. That's actually a really important question. There probably are different factors that are driving that. But all in all, I think these are really complex and complicated cases. I did this great show one time with Dr. Avram Blooming, the author of Estrogen Matters, who'd also make a great guest because he's so knowledgeable about the use of estrogen post breast cancer diagnosis. Now, in the real world, it's what happens. What's important is that as you as the patient meet or a menopause doctor and your oncologist should be talking to you together. And oncologists definitely do have, for better or for worse, doesn't matter, this very bird's eye view that since there was estrogen receptors on that tumor, we should steer clear from estrogen because it could potentially hurt you. What they don't talk about are what are the things that could potentially hurt you from not giving you a teeny tiny bit of it. And it depends. Did you have, surgery? Did you have a mastectomy? Did you have radiation? Did you do your years of anti-chemo medications like tamoxifen or aromatase inhibitors? So many different factors because there's so many different routes from our breast cancer survivors, particularly younger women, right? So a lot of it is very much on the side of, well, estrogen's really going to hurt you or estrogen could increase your risk for cancer. But what's really not on the menu is what about what happens to you in your body if we don't give you the tiniest bit of estrogen, right? Your vagina can become atrophied, your libido can go down, pain can be, happen with intercourse, relationships can change, your relationship with your body changes, your self-esteem changes, a lot of things change, your bone health, your cardiovascular health, particularly if you're younger. So there's just not one good, quick, short answer. It really is a very, very deep conversation. But for far too long, it's really been, no, you can't have this, end of story. Right?
What does it mean for your vagina to atrophy?
And I don't want that shit.
Yeah.
Whatever it is.
No,
I don't want an atrophy vagina.
No, you don't.
Now.
You
No,
don't.
but what does that even mean?
I don't know. I don't want to find out.
No, we need to. Our listeners need to know what an atrophied vagina is.
I'm saying personally.
No, I don't want. I don't know what that is either. But we need to know.
Okay,
so we don't get it.
Dr. Hirsch, please.
Preventative medicine.
Let's
all not get
atrophy.
atrophied vaginas. But what is it?
What is it? Right. Just imagine for 1 second before I answer this question. If men at routinely around 47 just started losing their testosterone and their
penis
scrotum
became
shriveled
atrophied
up, and their penis atrophied, do you think we would live in a different world?
Period. On God, we would.
But wait, I think what we're missing from this conversation is it would never get to that point. Because
it wouldn't. There would be
so much research. There would be so many anti-atrophying penis medications and how to keep your penis
non-atrophied,
robust and non-atrophied.
Robust.
So
alert.
Let's just say, what is an atrophied vagina? How do we not get it?
Yeah.
And then
if you got it, what should you do?
And then we need to talk about stuff to unatrophy it.
A long medical phrase that we can shorten by calling it GSM. And what GSM is essentially a reversal of your vaginal tissue to what it was when you were, 12 and then 7 and then 3. We didn't make estrogen when we were young toddlers, and our tissue wasn't meant to have intercourse, right? When we have estrogen, the tissue, and not just the vagina is a tube, but we're talking the labia, the clitoris, the perineum, the bladder, the urethra. The tissue is a little bit more acidic, and that makes it work in the ways where it's stretchy, it's more lubricated. There's more lubrication because there's good blood flow coming in there, taking care of basically the lower pelvic floor. When we go through menopause and we lose estrogen, we go through that reverse puberty. The pH becomes a little bit more basic. The cells stop making lubrication. It's not stretchy and elastic anymore. The tissue can thin and tear and bleed. It feels like you've got chapped lips, but your vaginal lips, right? And that's not just the labia. Again, it's the bladder, it's the urethra. So it can increase risk for urinary tract infections, possibly cystitis, which is just like irritation every time you urinate, pain with intercourse, loss of orgasm, decreased sensation. All of these things are really important as we age, not just for sex. We need to get away from thinking about our
peeing.
vagina just as
Yeah.
sex, right?
Yeah.
But for many, many
seriously.
things, right? So the way to treat this in really just straight out there is vaginal estrogen. Vaginal estrogen is extremely safe. And I really want to point this out that even for our breast cancer survivors, vaginal estrogen is really, really safe because first of all, vaginal estrogen is the kind that just like hand lotion, it's going to stay right where you put it. So if you're putting something into the vagina or if you're putting something on the labia or the exterior skin, it's going to stay right there. The vagina has the most estrogen receptors in the whole body. So it really feels it usually. It usually has the biggest impact in terms of just our genitopelvic floor health. So vaginal estrogen is really, really, really safe. It can be used by breast cancer survivors. We should be discussing this with your oncologist so that you're not fighting with your oncologist for something that could really prevent a lot of trouble down the road. But that is what it is. And that is how you prevent it. One of the things that I always hear that was often taught that just makes me cringe is, well, just keep having sex. It's got to be one of the most just
That makes me so angry.
just cringe-worthy things. I cannot tell you how many patients
Just
have
keep
told me that
doing
doctors are
something
like,
that is painful and causing you to tear and bleed and have cystitis and not be able to pee or
yeah,
It's terrible.
just keep using it. Now, the reason I think this came about, I know, is because when we're having sex, that can tell the body or supposed to tell the body like, bring some blood flow down here because like there's something going on. There's some vibration, there's some tissue movement. But like, how long does sex last and how much are we really having it? Like, come on, this is wild. This is not a good treatment for genitourinary syndrome of menopause. Period.
So this is so frustrating to me personally because
this is wild.
I mean, first of all, this whole interview, Dr. Hirsch, is going to save a lot of people. So thank you because this is just brilliant and so important. But I have had conversations with my primary care physician, with my oncologist about low libido, especially when I was on Lupron. I'm now on tamoxifen, and about vaginal dry. My coochie was so dry.
I
And
know it.
it was
I
so
know
dry.
it.
And I don't
Of
know why
course.
this would not have been a conversation. Do people just not care?
No, this is why this is so important. This is so important that we keep talking about this.
But this is
There's
beyond
not enough.
This is beyond a conversation, like you said, about sex. This is
It is
about
beyond a conversation.
I mean,
of just sex.
that's obviously part of it, and pleasure is a very important fundamental part of this stage and every stage of life, or should be. But this is about not being deeply uncomfortable
in your body. And it goes back to if this was a male-bodied person's issue, it would virtually not exist, right? We are taught over and over again to not have bodily autonomy, to be uncomfortable with our bodies, to just ride it out, to not have conversations about it. It's taboo to be open about it. And so we just suffer in silence. And I think it's directly connected also to our fear of aging. And we don't want to admit that we are getting older. This very youth-driven perspective that is foisted upon women. It's not just how we look physically, it's also how we feel. So we can't admit.
Right, so we can't admit that stuff that used to feel good or felt okay is now really uncomfortable.
Right. And how often do you go into your doctor's office being like, I just want to talk about female pleasure today and orgasm? Probably not all that much, specifically when you're
Tashira
talking about Lupron.
No, but I think
and you're,
there's something that we've been told or taught where we feel, like you said, shame around bringing some of these issues to the forefront. Maybe because we don't learn as them as medical issues, right? To me, when I learned about sex ed, it never felt medical to me. It was just around getting older. It was more kind of sociology than I mean, I know it was part of health class, but health class was never incorporated into science. in my mind,
Yeah.
as I grew. It was just, oh, we need to teach you this so you don't get pregnant or get an STI.
Exactly.
Yeah.
And ladies, and that exactly carries right into medical school. You would think, oh, well, they're training young minds and they're training doctors, and doctors probably talk about, menopause and low libido and vaginal dryness. Honestly, it's atrocious when you step back and you ask me or another professional, like, why are these things such problems? This is all exactly why. These are systemic issues that go back to our or women's or people with ovaries issues are just not seen as prominent enough to be talked about in medical school. I mean, one of the most shared articles of 2022 was Dr. Rachel Rubin's article
I love
and
her.
colleagues on clitoris, right? Why aren't we studying the clitoris? Why did no one talk to you about there are 2 non-hormonal medications for low libido that you're a great candidate for. Vaginal estrogen is something that you are a great candidate for.
Back
and
up.
someone should
What
be
are the
putting you on.
2 medications that are non-hormonal for low libido?
I mean, not sponsored, but we got to get this out.
But it's crazy to think that
Wait, I really want to know
there
what they are.
are these options. So the first is a medication called flibanserin, or its generic name is Addyi, ADDYI, if you're going to go Google this medication. It is FDA approved to treat hypoactive sexual desire disorder, which is a mouthful for low libido, but low libido that's bothersome is actually what makes it a medical diagnosis. If you just have low libido and you're fine with that, that's not a medical condition that you need to treat.
Right.
But if it's
Right.
bothersome to you, right, that's called HSDD. And Addyi is a non-hormonal medication that works to increase dopamine in the brain. It's also great because it can help you feel a little sleepy at bedtime and sometimes can help women lose just a few pounds. Okay, so that is our first FDA-approved medication for low libido. And the second is called bromelaninide, or Vyleesi, Vylessi is its generic name. And that is an as-needed injectable medication, almost like a pre-date night medication. Also works in the brain to increase libido, right? To increase sexual thoughts of
Oh, I'm getting this tomorrow.
But there's lots of ways to work with your clinicians to help you discuss or see if you're a good candidate for these medications, right? And it's a date night medication, so it's an as needed injectable. And the injection isn't sort of this like pull up this big needle and syringe it. It's one of those pens where a lot of medications are becoming these pens that you just kind of pop in your belly. And we have 2 FDA-approved medications. Why aren't people singing it from the rooftops? I do, and some of my colleagues do, but there's only a few of us.
And also, I think it really needs to be stated very loudly that Tashira and myself actually are fairly well versed in this area, not only from our own life experiences, but we are lawyers. We do a lot of research. We read a lot. And I have never heard of either of these medications. And it is only within the last couple of years where I have felt that there has been any attention to this as something that's important to society.
Period. And for
Yes.
me, in my case as well, and probably you as well, outside of Dr. Hirsch, I have asked specifically what can be done because it was an issue, and I'll be transparent, that really was starting to impede my intimacy in my previous relationship. I was begging for help and not receiving it. And so, of course, the issue is systemic.
Well, I've always just been told I was depressed.
And that goes back to like the antidepressant or the SSRI.
Which
that people
also
push.
makes you have a lower
Low libido.
Well,
Okay.
listen, here's what I say about that. Let's clear up the SSRIs for a second. It can reduce your libido because serotonin, which can help improve your mood, can impede libido. But there's also a balance. If you're
Yeah, of
so
course.
depressed or so anxious that you don't want to have sex, a little can sometimes go the right way. So the right dose can be okay.
Okay.
But you guys are absolutely right. As you're watching this and as you're talking, I'm just sitting back like, yes, disseminate this, because it can't just be a few doctors. It has to be
No, because
team
no
of
one
us
has
as women
access to you guys. I mean, we can talk a little bit about your new position and how you can see more people, but also there's an issue around equity, around access to seeing someone like you that we do want to talk about. But before that,
Oh, for sure.
let's talk about sex oil on Instagram. Would you ever buy something off of Instagram like sex oil?
Would I personally?
No. I mean, would you
No.
recommend?
She was like, I'm a whole ass physician.
No.
But what is that? I think
gosh,
I think it's a question. It's a question or something that I'm being a little tongue in cheek, although I did buy some oil off of Instagram. That I think a lot of people are kind of Googling in silence and being like, well, I don't know, maybe I'll try this because nothing seems to be happening. And I want you to talk about that.
This goes back to pellets. This is the same idea with pellets, right? If you were just offered vaginal estrogen, your vagina would be fantastically healthy, and you wouldn't probably need necessarily much more than that, right? And so because no one's telling you you can use vaginal estrogen, or there's all these different kinds of vaginal estrogen, and there's something called Interosa or DHEA. There's so many different types of things that I know that are FDA approved medications that are safe. That's probably what I will go to, or that's what I will use first, so that I might not need to go Googling down the rabbit hole and find something that's unregulated because I'm trying to solve a problem that my clinicians are not able to solve for me. And that's the same thing with pellets. That's why women get there, because their clinicians are not able to prescribe them. Maybe it's FDA approved hormone therapy, or maybe it's a non-hormonal option, or at least just have a discussion with them on what their safe options are. And because nobody will do that with them, they're just going to find their own answers. And that's the same thing with finding things on Instagram. Now, if they're not harmful to you, I don't care what you try, but pellets are harmful. And I have seen way too much harm come from those. And that's why I scream and scream and scream about it. But if it's sex oil, have at it. The worst that's going to happen is, you spend $50 on something and you're like, oh,
that's water.
But you might even have a little bit of fun.
Well, I mean, and also for me, because I haven't had access to this knowledge and, vaginal estrogen and other type of topicals, I have tried a sex oil before, and I've also had a lot of good results with cannabis. And with strains that are supposed to increase like libido and that are aphrodisiacs. That is a natural treatment that has worked well for me, speaking for myself.
Oh my gosh. So Dr. Becky Lynn, who's a gynecologist and menopause expert, and also is one of the leaders at ISHWISH, which is the International Society for the Study of Women's Sexual Health, a meeting actually to be held in March, which I'm going to speak at.
Ooh, yeah.
But she has done a lot of research on cannabis and sexual function, because in many states it is now legal.
Right.
And it is not surprising at all that it can improve libido. It's interesting to learn about its physiology, and we definitely want to learn more about this. But look, I think anything that we can do to help better understand women's bodies and to really look at what is on the menu, what can we really use, what should we study, that's something we should do. Now, is the NIH going to be doling out money for us to study, cannabis and women's sexuality, or testosterone and women's sexuality and sexual function? Probably not.
There
So
should
we're
be a
left with
Title
more
IX
limited
for
resources.
funding for health. Don't you think? I mean, it just feels so fundamentally unfair that in the
One-sided.
90s we had what's it called? Of Viagra and Cialis, and men's new, like, they can have vasectomies really easily. And
Yeah.
I mean, my heart goes out to men who have sexual dysfunction. Sure, of course. But I feel like there's so much that we don't know about women, and the research hasn't been there.
And this NIH piece
It
is
hasn't.
really important too, Dr. Hirsch, right? Because, I mean, funding from the federal government is where a lot of these breakthroughs happen, I'm sure, outside of like private, funding.
Exactly. So large academic institutions are going to rely heavily on NIH funding, and large academic institutions have the infrastructure to do big studies that are the gold standard, which is a randomized controlled trial. Now, in about, I think, a handful of years ago or a decade or so ago, the NIH did really try to make this statement, this movement to better include sex and gender studies in all of research, meaning studying statins in both women and men, studying aspirin in both women and men, because historically, even our fundamental medications that we use for basic things like hypertension and dyslipidemia, heart disease, etc., have all been studied on men. So the discrepancy goes back many, 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 many decades and is bigger than we even think. However, now that we are trying to incorporate what we scientists and researchers are really trying to be more thoughtful to include women in these studies, but now we have to go an extra step and say, well, let's just study just women's issues and not pregnancy and not contraception, but actually midlife and menopausal symptoms.
Okay, we have time for one more question, and I think how we decide what that question is going to be hard. But I'm going to just go and ask: do these symptoms abate, and is it true that really old people have crazy sex?
So the symptoms of menopause last on average 5 to 7 years. About 10% of women have symptoms that last the rest of their lives. And about 10 to 15% of women have no symptoms. However, if you have no symptoms, your body still changes. Genital syndrome of menopause still happens. Bone loss still happens. Brain changes still happen. And remember how we talked about those definitions. Once you're postmenopausal, you're always postmenopausal.
Okay.
So whether you feel the hot flash or not, your body fundamentally changes and it's never the same. And it's so important to know what you need to do to set yourself up for success. Everything that we've talked about in this episode. Now, can sex get better? And does sex get better? It definitely can. It definitely does for some people. But one of the important things about sex getting better is that if it's like riding a bike, if in our 40s, when we're starting to feel terrible and our kids are getting older and we're worrying about our kids, and we're worrying about our parents, and we're worrying about our finances, and we're worrying about all these things, and sex just becomes less and less of a priority, which is okay. That's fine. But the longer that time goes on that you haven't ridden the bike, and no pun intended here, okay, guys? The more work it takes to kind of get back into that thing, right? So it has to just be a priority. You just have to make it a priority. And I think that menopause for a lot of women can be really relieving. Like the entire fear of getting pregnant is now gone. Like, yes, you don't have to worry about
pressure to get pregnant.
Or exactly. You don't have to worry about the pressure to get pregnant or the worry not to get pregnant. There's lots of sexual liberation. We know ourselves better. We know our bodies better. We know what we like. We know what we don't. Like, we know so much more about ourselves than when the first time we had sex, which just probably felt so weird and awkward and off. It is a great time to really be in your sexuality. But just remember, when there's a time in our life when it's a lower priority, which inevitably happens, it happens, and all women think that they're the only people not having sex. Let me tell you right now, most women, 40s and 50s, that's when we are not having sex, and that is A-okay. Now, if you are, great. If you're not, great. But if you want to make it a priority, just remember, you have to have healthy tissue. You have to have a body that's anatomically going to let you do that and enjoy it.
And not atrophied.
That's where not atrophy. That's where that vaginal estrogen and GSM comes back into play. And then, it's about setting your body up for success and then setting your mind up for success. All things that we can definitely do. And so trust me, once the family moves out or all those stressors of our 40s and 50s are past us, yes, go crazy.
Thank you so much for saying that, because I feel like when speaking about sexual liberation and sexual health, one of the things I want to plug, no pun intended, is anal. I really want to plug it. I was telling Margot.
Plug it.
I was telling Margot earlier.
Look at Margot. She's dying right now.
I was
keep going.
Girl. I was like, I have been open to anal and it has changed everything, Dr. Hirsch. It's been amazing. And we're not talking about this, the different ways of experiencing intercourse, especially if you're a little nervous or anxious about your vagina being atrophied. we have other ways of experiencing. And anal is great.
Yeah. There's so many ways. So many people find pleasure in things that they just shut down about, or they're,
So
they
I
haven't
find
tried.
a lot of
And you know what?
pleasure in linen sheets and napping. And I just want to plug napping and the soft life, right? Okay, whatever.
I hear you. I think the spectrum on pleasure is what's so important here, and opening our minds to experiences that we never thought maybe we would like. And you might try it and you say, nope, that door is shut.
But
no
I
pun
also
intended.
think it's exactly. And I actually think this is a really great way to end the episode insofar as we as a society have put a lot of rules around what it means to be middle age, or we call it big age, Dr. Hirsch. And one of our goals in doing the podcast and having these conversations and being transparent around them is that there shouldn't be rules. We should be investigative. We should be transparent. We should be honest with ourselves about what we like and what we need, and what I need and what Tashira need are going to be different as what you need and anyone else kind of going through some of these experiences. And all of those, like you said, are right. There's no one way. But
there's no one way.
But pleasure is something that can be experienced in this age, and we just need to set ourselves up for success like anything else.
For sure. Thank you so much, Dr. Hirsch.
Oh, thank you guys so much. What a fun, refreshing, open, honest conversation. I'm so delighted and excited for you guys to have this podcast and keep disseminating all of this juicy information.
We're gonna keep on this topic, because
I mean, if this was the first one you recorded for the year, I think you're on a roll.
You literally opened a lot of doors for us today.
Absolutely.
Avenues for investigation, and not just going down a rabbit hole on Instagram. So thank you.
Yes. You're welcome. All right, guys. Thank you so much for having me on. It was an honor.
Oh, thanks, Dr. Hirsch. Well, thanks, Shai, for this really interesting conversation. I'm still processing a lot of the information that we learned, and I can only imagine for folks who haven't started thinking about perimenopause or menopause, or who haven't had the access to speaking to someone like Dr. Hirsch, this episode will be helpful. I hope it will be helpful.
Absolutely. And everyone, please stay close to all of her channels, places to find Dr. Hirsch. We will link in the show notes.
Absolutely. And let's keep this conversation going, because I can only imagine how much insight our listeners and viewers have around this subject. And this is a conversation that's just started.
Absolutely.
So thank you, and stay tuned.
Stay tuned for the next episode.